Good morning, everyone. Welcome to the MAC meeting. We will just give it another few minutes for others to join. It's just right at 10 o'clock right now. If you are a committee member who is on the phone, if you would unmute and let me know that you are here. But we'll just give it another minute or so for folks to join. Thank you so much. Appreciate it.
This is Daniel Sarge with the Utah Healthcare Association.
Thank you. Thank you for letting me know who's on the phone. I appreciate it. Okay, again, welcome. Thank you for joining the MAC meeting today. Rachel, we've got a quorum by my count, so you can start the meeting whenever you are ready. Thank you so much. Appreciate it.
Thank you, Sharon. Hi, everyone. Welcome to our June MAC meeting. Thank you all for being here. We actually have quite a few announcements and votes today. So we'll start off I will take a motion to approve the May 2026 minutes, if anyone would like to make that.
I move to approve the minutes.
Thank you. Thank you, Casey. We will vote by silence as usual.
Sorry, just one moment. Was that a Casey seconding? Only committee members can actually vote on the approval. So we need another second, I do believe.
This is Nancy. I'll second.
Thank you, Nancy. And as usual, we will vote by silence. Anyone have any issues with approving the minutes? Hearing none, I will rule those approved. Next order of business, we will have chair and vice chair appointments. Sharon, remind me, is my last MAC meeting August, or is August when we'll have the new chairs?
So your last MAC meeting will be August. So you have one more to go after this one, Rachel. And just to kind of go a little bit further, we do have several people interested in the vice chair. So Dr. Jennifer Brenton will become the chair starting in the October meeting. And then we will have a vote in the August meeting for the vice chair appointments. And then whoever ends up being the vice chair and Dr. Brenton, their first MAC meeting, chairing will be in October, which is our next meeting after the August one. So hopefully that helps explain that, Rachel.
That does help. Thank you, Sharon. And I'd like to remind folks as we head towards, I guess, voting on a vice chair in August that me and Dr. Britton are technically both provider representatives. So we would like to see, Sharon, I have to assume that we have some consumer representatives that are interested this time in the vice chair, but I just want to remind folks of that.
Yes, that is correct. Thank you for bringing that up. So all of the individuals who are interested in the vice chair appointments, they are all consumer representatives. So definitely going back to Dr. Brenton's a provider representative, and then the vice chair will be a consumer representative. And then the member at large, so just to kind of state for that position as well. So right now, Daryl is the member at large. And so the chair and vice chair will select the member at large, and that one can be either a provider representative or a consumer representative. So it can be either appointment.
Perfect. Thank you. Do we have any questions about the chair and vice chair appointment process? All right. Hearing none, I'll also let folks know that we have open appointments as well. We need a consumer rep for the behavioral, from the behavioral and mental health sphere. And then we also need a consumer rep for the senior citizen community as well. So if you know anyone that is interested, please have them reach out to Sharon or even myself, and we can make sure that they are applying. When were those, Sharon, can you remind me when those appointments would start?
So the one for the behavioral and mental health, so that appointment actually ends in August. So it'd be great if we could have somebody start for October. And then the other one for the senior citizen community, that appointment ends in October. So that one would start in January.
Perfect. If you have any questions, please let us know. But does anyone have any questions right now about those two open seats, or soon to be open seats, I should say? Okay, hearing none, I think we can move on to agenda item number 2. But as a reminder, any questions about appointments or open seats, feel free to reach out to Sharon or myself or Dr. Britton, and we'll make sure those questions are answered. We'll move on to agenda item number 2, which is discussion and vote on the budget recommendations. So I will admit that I only just voted today. So Sharon, is there anyone else that needs to vote as a reminder? I don't know if it's too late for them, but I just wanted to make sure that we're making that announcement in the case that people haven't voted and still have time.
Yes, so the MAC members do still have time, basically right after this discussion on the budget recommendations. And if there's any questions, so this is the time to, if you've got questions before you want to vote. I think I only have a handful. Rachel, if you voted this morning, then I believe I've got 2 more that if they could go into RedCap and vote, or they could send me their ballot via email. And then I will be tallying those votes during this meeting and reading them off at the end of the meeting. So yes, there is still time for those who have not voted yet to do so.
Perfect. Thank you. And are there any questions about the voting process? I'm not sure that we have presenters here to answer any of your questions from the actual presentations. Some of them might be here. So if you do, it's worth trying to ask, but I'll be quiet for a second and see if there's any questions. Okay, hearing and seeing none. If you have not voted, please do. You do have some time to do that. It doesn't take that long. And you should have an email from Sharon with the survey link and the actual filling out chart. Sabra, sorry.
Yes, sorry, I was trying to raise my hand, but
Okay.
when you vote, it says thank you, but it doesn't send you anything that it was received.
I did not get anything either, so I would just defer to Sharon to make sure that your vote got in.
Yes, I don't think the system is set up to send you the responses. If you would like a copy of your responses, let me know and I can send them out. Sabra, I can confirm that I did receive yours. So if you do have any questions about whether or not I received it, you can reach out, but trust to know that I have also reached out to individuals as a reminder, and I'll be doing so today as well during this meeting. Once I go back in and kind of see who's voted, if there's anyone who hasn't voted quite yet, I will be reaching out to them during this meeting. So
Thank you. I figure it probably made it, but I just wanted to make sure. Okay.
yeah, yep, absolutely. Thank you for confirming.
Any other questions about voting? Okay, hearing and seeing none, I believe we can move on to agenda item number 3, which is the MAC annual report. As most of you should know, Sharon sent out the MAC annual report. That is a new requirement of all Medicaid advisory committees that they submit that report annually to CMS. So we've had some time to review that. I believe that the deadline has already come back for feedback. So are there any questions before we take a vote? Okay, hearing and seeing none. I believe for this one, Sharon, do you need to like record our actual votes this time around for this one? Is there any difference, or can we continue to vote by silence unless if there's something that indicates otherwise?
I think you could do it the same as you do with the meeting minutes, unless anyone wants to do like a voice vote. I can certainly do that, but I don't think we discussed that, so it's really up to you.
Okay.
If you want to do a couple of motions and then by silence.
Yeah, let's try it that way. And then if there's, a bunch of, people not wanting to approve these, we can discuss. I will take a motion to approve the MAC annual report for 2020, July 1st, 2025 to June 20th, 2026.
This is Emma. A motion to approve.
Thank you. I will take anyone seconding that motion.
This is Nancy. I'll second.
Thank you, Nancy. And as usual, we will vote by silence. So if anyone has any concerns about approving this, please let us know now. But if not, we will consider your silence approval. Sabra, is your hand still up from before? I assume yes, but I just want to be sure.
Oh, yes, sorry, I forgot to turn
You're totally fine. All right. Hearing and seeing no opposition, I will rule that report approved. And we can move on to agenda item number 4, which will be the Notices Committee report from Tatiana Matuas.
Good morning, everyone. I would like to share a brief update of the notices reviewed to the work group. Since April, the group has reviewed more than 25 related to approved denials and case closures. The group also had the opportunity to review a new HR1 community engagement and eligibility review notice, which will be mailed next month to all adult expansions and target adult members. Our ongoing focus areas include, first, using plain language to make notices easier to understand and follow. Second, highlighting key sections, such as important information you should know. Third, improve visual layout through clear headings, bullet points, and formatting. 4, using bold text to emphasize urgent or time-sensitive actions. 5, clear stating what action is required and what the line. For example, to keep your Medicaid open, return the verification by June 30th, 2025. 6, include contact information, Department of Workforce Services or DWS business hours, and other helpful resources when applicable. 7, ensuring applicable Medicaid and or CHIP policy reference are included. And 8, confirming all notices align with current guidance from the Centers for Medicare and Medicaid Services. Overall, the group goals remains to improve clarity, accessibility, and effectiveness of members' notices so individuals can better understand their benefits, responsibilities, and requirement actions. Thank you.
Thank you, Tatiana. Does anyone have any questions for Tatiana on the notices committee work? Okay, hearing and seeing none. Thank you, Tatiana. And just as a reminder, the notices committee is open to anyone who would like to participate. So if you are interested in helping review communications that come from DHHS/DWS to Medicaid members, please let Sharon know or someone else know, and we'll get you part of that committee. And then we can move on to agenda item number 5, which is update on Canopy Inc., which is a Medicaid pregnancy app. And so I'll pass it off to Lauren Lang and Brian Roach.
Yeah, thanks for having me today, guys. So let me just share, we got a quick presentation I think Sharon sent out yesterday, but bring it up. Okay, so I'm just going to give kind of a brief update about the Canopy app and kind of what it is, how we came to contract with this company, and kind of what our next steps are. So what was the purpose of the app? So the purpose of the app is to provide a pregnancy and postpartum application for Utah Medicaid members that enhances access to recommended pregnancy and postpartum care, helps members navigate their pregnancies, and improves access to Medicaid benefits. And then the expected outcome is that those that use the app will have a better self-perceived understanding of prenatal health care recommendations and Medicaid resources available to increase their access to care during their pregnancy and postpartum period. I'll hand it over to Brian to just touch briefly on the funding and RFP.
Yeah, thank you, Lauren. This item was identified as a priority through the Governor's Office and Office of Families back in, I believe, 2024. So the funding amount was low. We determined that we could implement it within our existing budget because the funding requirement was so low, and we chose to introduce this as a competitive RFP. There are details about that procurement process that I can share within this MAC meeting chat, but we did go through a competitive RFP through 2025, advanced through an award, and Canopy was the app that was chosen through that process. And thanks, Lauren. I'll pass it back to you.
Thanks. So what is Canopy? I'm going to bring up the landing page real quick that we have that for this partnership. And it gives kind of an overview of, find it. There we go. All right, so this is the landing page that Canopy has created for the contract with our division. And basically goes over the basics of the app. We've got in-app resources, personalized programs, and virtual classes. And I'll go over this in a little bit more detail as well. How the login works. So you can easily enroll via the link or the app. And then they'll give like a brief little questionnaire and kind of any areas of concern that the member has, things they might need more resources with, things of that nature. And when they log in, all that's going to happen is that they will select Utah as their state and Medicaid as their insurance or health plan. And then they'll get complete access to the app that way. This landing page kind of goes over a brief update of resources available, 24/7 mental health support, kind of some topics that might be of interest. So this is the page that we have been using to primarily communicate the app's availability and kind of what's involved. And we've been sharing that with our partners to try to get some more enrollment for our members. So that website is there in the slides if anybody wants more information. And I'll kind of flip back over and give a bit more detail as well. So what is Canopy? Canopy's main drivers are to provide preventative care, especially in remote areas, provide resources, and to address social determinants of health gaps, and community with other moms and families. And I should mention these next few slides are provided by Canopy. So about Canopy, they're a maternal health platform and AAP Star Center resource serving 50,000 plus moms across the US. They have deep Medicaid and public health experience with these states listed before they came on board with us. Compassionate, personalized preventative care for underserved mothers. And before the contract, they were reaching about 500 moms across 17 counties in Utah. And since then, we've had more enrollment, of course. So a little overview of the platform. Generally, it's engaging, warm, destigmatizing. There's optional co-branding, which we haven't done a lot of in the app yet. It's available as a web app in iOS and Android. As I said, the member will just log in and select Utah and Medicaid as their options to get access. And then they automatically get tagged for state or zip code specific resources. And then because this is provided to Medicaid members who are in the pregnant women benefit plan, once they have been in postpartum for 12 months, which is when they would be disenrolled from the benefit plan, they're also disenrolled from the app. System navigation and experience. So they'll get a personalized homepage, image forward interface, kind of the core program with audio, text, and video-based sessions. And they've got 44 sessions, which equates to 2.5 hours of a therapeutic program aimed at improving mental health, and as well as weekly gestational age-based education and content, which all comes from peer-reviewed sources such as ACOG, March of Dimes, CDC, AAP. And it's not just a content library, it's also a programmatic maternal health intervention based on evidence-based behavioral science. So every mom gets a personalized preventative program. The goal with that is to drive engagement, improve outcomes, and also improve Medicaid benefit utilization. And before we started this program, their stats were about 86% of Utah moms completing onboarding, 92% report feeling better, and 80% at risk for depression improve during over the course of using their resources. So the content, this screenshot on the left here just kind of gives an idea of the email series. They have about an 85% open rate on those. And then they also will do some push notifications through the app, and that will come in as screening and milestone check-ins periodically as well. So yeah, we've got gestational age nudges, prenatal and postpartum education, mental health modules, crisis links, all vetted, of course. And then the content is continuously updated based on feedback, and kind of not just from members, but from us, from our other JHHS partners. If there's anything else that they want added in there for resources, then we can go ahead and update that really quickly. Languages for the app. So the app and the landing page that I showed at the beginning are available in English and Spanish. It automatically will adjust based on the settings in the phone or on the desktop. But if that does automatically, there is an option to manually change the language on that landing page down at the bottom. And they're available in English and Spanish. And then we will also be introducing Arabic, Pashto, and Chinese by the end of 2026. And the reason why we picked these 5 languages is because they represent the 5 primary languages for pregnant Medicaid members currently enrolled. So I'll just bring up the sign in. So this is a desktop version of what the app looks like. Just going to use my login. Give me a moment. Oh, sorry, I'm in the wrong place. So this is what the app looks like now. So this kind of what happens when they log in on their phone. It will bring up how many weeks and programs that they've started or things that they have to continue. Bring up some virtual classes as suggestions. Up here in the top right-hand corner, we have resources. So we worked with our DHHS partners to create quite a involved list of resources available to our Utah moms. And we've got mental health, we've got childcare, we've got food, formula, healthcare, links to help with providing or finding providers, transportation, housing, all sorts. So a mix of Medicaid resources, but also just general GHHS resources as well. And they'll also get push notifications along the way about things that are available through their Medicaid benefit that they can use. There is the program details here, so different sessions that they can take based on challenges that the member identified on login. There'll be information on different topics listed here. They offer online classes on a variety of topics provided by licensed and registered providers. So they can sign up for those here, just kind of general labor, sleep, nutrition, well-being, pelvic health, things of that nature. And they've also got a lot of parent stories here. So the idea is to kind of provide community for these moms, some narratives from other moms and their experiences, other parents. And they've got different topics up top here. And then the kind of a overview of what they've done so far at the end. So that is kind of what it looks like. Let's see what else have I gotten here. Is there any questions or anything as far as promoting the app? We have sent out MIBs. We have a new banner on our app on our website that just went live today that links to information existing on our Medicaid website around the Canopy app. Sorry. We've also been promoting the app through meetings with our other DHHS partners. We'll be reviewing it in our statewide provider training in September. Yeah, so hoping to get the word out and kind of improve enrollment. But yeah, we've been live for about a month now. Alicia?
Yeah, I just was wondering, I couldn't tell on your resources, do you have like the home visitation programs as a part of the resources in there? They are awesome.
Yes, they're in there, yeah.
Okay, thank you.
Lauren, my question, so now that I kind of like understand the app a little bit more, it looks like it's more like connecting patients to resources rather than it's like, I mean, there's some classes on there, right? But I think what I got like question wise from providers was just like they were thinking that I guess, just correct me if I'm wrong, there's not information that like a provider would need to know that's going to live in Canopy that's not going to get to them. That's kind of was their biggest question. Like, I think there was like a misunderstanding that maybe this app was doing some like telehealth, which it doesn't really seem like it is.
No, so they do offer, yeah, like you said, the classes, and they'll like link to access providers, but no, they're not providing telehealth through the app. They do an Edinburgh postpartum or prenatal depression scale, but that information is just basically used to link them to appropriate resources. And if they screen high on any of those, it's done repeatedly throughout the app to kind of see how their mental health is progressing with using the app's resources. And if they ever screen really high, then they're automatically directed to a page to call like 988 and a list of other emergent resources. So there's nothing that outside of that, there's nothing collected that would alter a healthcare plan or anything like that.
Awesome. Thank you so much.
Yep. Any other questions?
I guess one more question related to that. And I know that there's probably a lot of moving parts with this. If someone does screen really high for the depression scale and they do get routed to a screen that tells them to call 988 or other resources, obviously the app isn't necessarily going to know if that person does that or not. Does it flag that person for a follow-up in any way? Like, I know like kind of gets complicated with like, it's not a telehealth app. There might be some HIPAA stuff. I just was wondering because like if someone scores really high and then they don't end up calling for whatever reason, like, you know, that kind of creates a strange situation, but you can't, I mean, it's not like you can force someone to get care. Right? So
Yeah, so because of HIPAA, we can't allow them to even take like a Medicaid number from these members. That's why that they automatically just click Medicaid and they gain access. So we don't have the ability to follow up, but they have like a lot of disclaimers within the app that say like this isn't a medical intervention, like this is just a resource, like these are those kind of like legal disclaimers. But yeah, we have ways to identify who is screening high, but there isn't like an automatic follow-up process.
Gotcha. That's what, yeah.
That makes sense. Yeah.
Any other questions for Lauren or Brian on Canopy?
Stephanie asked about the contract, and Brian can share that.
Yeah, just for the sake of crossing our T's and dotting our I's, the process would be to do a grandma request. So Stephanie, if I can ask you to do that, but we can share through that method.
Any other questions? Okay. Thanks for listening, guys. Yeah, feel free to reach out if any of the other questions come up. Happy to answer.
Thank you, Lauren. Thank you, Brian. We appreciate it. I believe the next item on our agenda is, I think it's the HR1 update from Director Ewing.
All right. In the last, I guess I would say a couple of months, we've had a flurry of activity at the federal level in terms of guidance that has been issued. I know that the major concerns that this group probably is most interested in is a discussion of the community engagement requirements. But I did just want to briefly mention that we do also have in terms of regulations that have come out over the last month. On May 22nd, we received a new rule regarding state-directed payments and provider taxes. And we can discuss that at a future MAC. I know that that's been a pending discussion item to have an in-depth conversation on that, so we can put that on the agenda for a future MAC and we can talk about these changes there. But I did want to flag that. And then the other item I also wanted to flag is that on June 11th, we also received it was a state Medicaid director letter relative to budget neutrality and certifications of 1115 waivers. So for 1115 waivers, they have to, in order to be approvable, they have to meet a budget neutrality requirement and basically showing that they're cost effective. CMS has come out with this guidance that it makes some key changes to budget neutrality, including requiring a prospective actuarial certification. It eliminates some flexibilities relative to automatically deeming certain baseline authorities to be budget neutral that we could, previously just deem as being budget neutral. And then it restricts some savings rollover. So it makes some really technical changes to how we might calculate the budget neutrality. And we know that this is going to require us to utilize an actuary now to do that work instead of most of the form used to be an Excel spreadsheet we were able to fill out. So we were expecting some impact there. So I did also want to flag that before we get into a discussion of the other big rule that came out. And when I say big, I mean big. It was 370 some odd pages on June 1st, which was the interim final rule, which gave us the comprehensive guidance on community engagement. So I think most folks are aware of the new community engagement requirements which are coming out, which are also called the work requirements. And the work requirements in this rule, again, it clarifies that the qualifying activities for work requirement include standard employment or self-employment for 80 hours a month, enrolling in an education program at least half-time, job training or vocational programs for 80 hours a month, community service or volunteering 80 hours a month, or a combination of some of those activities. And the interim final rule also clarified who those community engagements will require to. So it gave us a new definition of applicable individual, so that to identify who would be subject to those requirements. Other things I would note of importance for this group, the rule also came out with clear information about what we will be able to consider a medically frail exemption. So under HR 1, it did clarify, it did state that there would be a medically frail exception for individuals so that the work requirements would not apply to them. And so this interim final rule states that to qualify as medically frail, an individual must fit into one statutory category, which is blindness or disability, a substance use disorder, disabling mental disorders, physical, intellectual, or developmental disabilities, or a serious or complex medical condition. And the rule also adds on what is being referred to as an impairment test. So the rule also mandates that in addition to one of those 5 categories you must meet, you also have to show that the condition would significantly impair your ability to function to satisfy meeting that exemption for medical frailty. The other thing the rule did that I think is worth noting is it made clear that homelessness itself could not be considered a medical frailty, but they did acknowledge that an individual experiencing homelessness could have, one of the conditions, likely has one of the conditions that could have them meet the medical frailty exemption. We've put together, I'm giving you again some high level highlights of what I feel like might be relevant, but my team has also put together a summary with a little more detail that we will be providing out to the group. The last thing I just would like to say that what does this mean for Utah? What does this mean for our population? Our estimated population that will be subject to these rules, because again, it only applies to expansion. It doesn't apply to our legacy Medicaid population. So we estimate that about 85,600 residents fit into the criteria for having to meet the community engagement requirements. And we expect that approximately half will meet one of the exemptions that are baked into the work requirements. And then, so based on our current models, we think we would see about a 17 to 25% drop in our monthly Medicaid expansion enrollment by 2028 for individuals who didn't comply with the work requirements. So I will pause there, and I'd be happy to answer any questions that you have about the HR 1 rules.
Julie, can you repeat the percentage of drop that you're expecting?
Yes. So we're expecting anywhere from 17 to 25%.
17 to 25. Okay, thank you.
I see. Sabra?
Yes, Sabra.
Oh, Sabra, sorry.
Wondering, so this rule is here now. There's no chance of it being rolled back or reversed.
So it is currently an interim status. So I think the public comment period is still open. I'm not quite sure when the end date is. Maybe Brian or Michelle, if you want to jump in on that one.
Yeah, so I believe it's the end of July. Is that correct, Brian?
Yeah, thanks. And also just I'll note, because this is really like the implementation details of the congressional action of HR 1. So, I mean, HR 1 would take an act of Congress to undo. This rule is just how to implement that congressional bill.
And so some of the details in the rule could change if public comment or, political will demands it. Yeah, some of the criteria won't be changed because it is part of HR1.
Thank you.
Dr. Ferguson.
Yeah, I had a question. So they really have the expectation that if someone is unhoused and under-resourced, say for even just access to food, which many of our unhoused folks are often unable to meet many of their medical needs, let alone their dietary, they are expected to either enroll in a class for 20 hours or volunteer, knowing they're going from possibly in a shelter at night and during the day. Like they're expecting them to be able to comply.
Unless they meet one of the medical frailty exemptions, yeah, that's the expectation.
Okay. All right. Well, thank you.
And then I see Daryl.
Hi, thanks. I was wondering if you could give an update on on self-attestation in the state, and I kind of lost track of how that's going to, what the recent bill was that passed and what the interplay is there, because I think the interim rule would allow it for a year.
And I'll ask Brian or Michelle to jump in on that one.
Thanks.
Yeah, happy to. I think we're talking about medical frailty, but
Yes.
Yes, okay, Daryl, in that respect, yes, there is an ability, and state law also kept this as an ability for an individual to self-attest. So just to make sure, I think Daryl, you understand this. So, but the whole group understands. We'll use data first to try to identify individuals as medically frail using like our claims and encounter data. But for some people, they're new to Medicaid. There will be a screener that is available that does allow individuals, when they're going through the enrollment process, to self-identify as medically frail. We're trying to work on some very simplified questions to that effect, and they'll be able to self-attest under penalty of perjury, but that would allow us to recognize medical frailty. The rule, as I think you were mentioning, does set up a higher standard after a year. So beginning 2028, individuals would not be able to do that again unless there are, it would, let me restate, it would require after 2028, anyone who has used that self-screener would be expected to have either their claims data that we receive demonstrate medical frailty or other documentation. So it does set a little bit higher bar beginning in 2028 for members who have used that screener. Does that help answer your question?
Yes. Is it impacted by State Bill 471 at all?
No, it's a good question. House Bill 471 did allow for this process that I described. It did allow us to use the screener to, I think it uses language like provisionally approve. My interpretation is that this is within that scope. So it didn't present a conflict in my interpretation between the IFR and House Bill 471.
Thanks, Brian.
And then Andrew.
Good morning, Julie. Do you know if Utah and or other states are preparing to or preparing to or actually giving feedback to CMS about the challenges that you all expect to encounter in terms of determining whether somebody's diagnosis or condition prevents them from working at a specific level?
So I think right now our plan is to provide any comments we might have through NAMD, the National Association of Medicaid Directors. We've also had some outreach from our federal delegation relative to finding out what our concerns are. So we'll provide feedback there. And it's, you know, a couple of the legislators from the federal delegation. And so we will provide some input there, but at this point, as a state individually, we're not planning on providing public comment on the rule.
Thanks.
Wanel.
Thanks, Julie. So my question is related to the medically fragile list. I believe in the interim final rule, it mentions that each state will come up with their own set of conditions that they believe fit, like the eligibility requirements for exclusion as medically fragile. It appears to me, and there's like an appeal process for people with conditions that aren't specifically mentioned in that list. I guess question one is that true? Is there like a list that the department is developing? And I guess number two, what's the approach in identifying these conditions that would be eligible for exclusion from the work requirements?
Yeah, we have our medical director working on that list, but Brian again has been leading that effort. So you want to talk about that one?
Yeah, thank you for the question. So yes, Dr. Iqbal, our medical director, is helping to develop the list. And I think we actually presented in prior formats or prior forums, our community partner engagement group or some other group, but we are like revisiting that list in light of the IFR and that requirement to have the condition substantially impair, because for some conditions it will require more than just a diagnosis code and potentially include more indications such as pharmacy utilization or emergency department visits. It does make it more complicated, but thankfully Dr. Iqbal is helping on that effort. It is also still important to note that the lack of claims data that makes someone eligible based on data we have is not the only it's not the only method to determine medical frailty. So just a second ago, I was mentioning, as in response to Daryl's question, that self-screener is an ability for members. And then also beyond that, we will also offer the opportunity for documentation from a qualified health practitioner, whether a physician or other qualified healthcare practitioner, to provide a form that demonstrates medical frailty. We are still working on what that form will look like. We, back in the day, had a similar form for documenting medical frailty. We're looking at bringing back something similar. But those are efforts we're undertaking to demonstrate that.
Thanks, Brian. And just a quick follow-up to that. I guess each state would have their own list of conditions since we're developing it independently. Is there any coordination that's occurring between states to have a more uniform? Like, is there any like discussions on that end, or do you expect there to be like individual states, individual lists?
Another great question. We're trying. We really are trying hard to get other states' interpretations, other state lists. Some are being shared around. very few. There were a group of Western states that had one. Nebraska implemented this program early, and I do believe their list is public. I can try to find it in the background. But we are, for the sake of understanding state decisions so that it helps inform us, yes, we're trying to see what other states are including. Ultimately, we will be accountable for our own list. So we're just keeping that in mind, that I don't think we'll have exactly what some other state has, but we'll probably use them for guidance through the process as we come to our final list.
Thanks.
Sabra?
Yes, I had two more questions. I didn't notice if deaf people or wheelchair users are on that list, and why are they using the term medical frailty because instead of disability? And I did have one more question as well. They say work or community service. So how do they determine what community service qualifies, and do people have to log it, etc.?
Go ahead, Brian.
Yeah, maybe I'll address the medically frail and then allow Michelle to address the other component of that. So, so wheelchair use. So it is important. So first of all, the term medically frail, that is defined within the law. So we use it because it was defined there. The very first subcomponent of that definition within HR1 is an individual who is blind or disabled as defined in section 1614. So an individual that meets that along with the interim final rule definition that their disability does substantially impair the ability to participate in community engagement would qualify. I don't know, this might be a question for Dr. Iqbal, whether wheelchair use falls into that. I'm not sure myself, but it is potentially a scenario we could talk through or determine after the fact.
Yeah, Brian, I can make a comment. So we've been discussing back and forth within our Medicaid Medical Director group, which comprises of all the state Medicaid medical directors. There've been some mixed signals from CMS, whether being legally blind or deafness would account for the medical frailty exemption, since people who are either legally blind or deaf can still use sign language or could still do some other work that would allow them to have some community engagement. We are not entirely clear. This discussion has been brought up multiple times with multiple states. It's a work in progress, and as soon as we have clear guidance, we are happy to share that. Regarding wheelchair, I do not believe just being in a wheelchair would be an exemption, sadly.
Okay, I can take the community service question that you had. So I'm going to drop in the chat here just kind of a summary of the definition that CMS provided in the IFR around what qualifies as community service for participation. So this right here just defines community service as unpaid work completed under a structured program for the direct benefit of community under the supervision of a public agency or nonprofit organization. And the agency or organization must provide oversight, maintain a process to track the type of activity, dates, hours completed, and include a point of contact. So for year one, our work group, we're working through, trying to set up the paths, not just a community service, but any path that somebody chooses to take or can take to meet compliance. That could mean referring individuals to community service and working with those organizations to gather that information. It can also be creating a form that we're working on right now as a work group to capture self-attestation of those hours. So that would be for year one. For year two, meaning like post go live, so January 2028, we are actively working on trying to find ways to create some sort of electronic data source or connection to an entity that connects with the various community service or volunteer organizations in our state to be able to just get that information electronically sent back to DWS so that it doesn't take additional documentation that someone has to provide. So hopefully that helps, but if you have more questions for me, please let me know.
Yes, I did actually have one more question about the medical frailty thing. Even SSI recognizes that deafness and blindness can impair someone's ability to work, especially with that no one's hiring deaf and blind people and the lack of accessibility that locks deaf and blind people out of the workforce. Yet there's still discussion that deaf and blind people are going to be excluded from the medically frail category, while people with mental health conditions are being included, even if they could work more easily.
Yeah, thank you for your comments, Sabra. I think we're still trying to just interpret this interim final rule within our regulatory requirements. One thing made super clear within the rule is that there states will be subject to audit, and we are just mindful of our compliance responsibilities. We'll also note, I think Julie mentioned that there are comments possible for any member of the public to make through the interim final rulemaking process, and you may choose to do so.
Rachel?
Okay, I have a comment and then two questions. So I'm sorry. The comment would be in terms of including, and I'm sure you guys have had this discussion as well with both people in Utah and, with other states as well. But I think from my perspective, because we've added this extra, because CMS added that extra hurdle of having to determine if their medical frailty diagnosis or their diagnosis that falls under the medically frail definition also has to impair them from working. I think in terms of how I think about it, it makes more sense to include certain conditions, even if they might not make that person unable to work necessarily, because we do have that extra bar where we have to be going in and saying, okay, this person has a diagnosis that is considered medically frail, but does it actually make them unable to work? And so that would be just my thought there as we're kind of just, if you guys are discussing that and putting the code list together. I think, because we have to go a step further and make sure that medical frailty diagnosis code makes it so they're unable to work. To me, it makes more sense to include more things than to not, because, someone's level of, if we're talking about like a disability, some person's level of disability is going to be different, even with probably the same diagnosis code. That's just my 2 cents. That makes sense. And then my question was first one, and I'll wait for the second one. And on the first one, when you guys were modeling how many people would be impacted by the work requirement, did you guys model just based on who you expected to have exemptions, or who you expected to actually, do all the paperwork and actually get those exemptions? You know what I mean? Like, does your modeling put into or did your modeling consider that, you know, certain people are going to give up or forget or, you know, mess up the process?
You, Rachel, for both questions. I think first one, and I'd be happy to go into like some of the code discussion in greater detail. It's really important to note that like the absence of a diagnosis in the algorithm we're creating to look through our data to identify someone as medically frail. If there's the absence of a code or absence of a diagnosis in that list, that is not determinative enough to say that the member is not medically frail. That does not close the door to them demonstrating medical frailty. They can still use the two other methods, so that the screener as one option or providing documentation through a qualified healthcare practitioner signing a form. So we are not making, we're not saying like such and such a diagnosis could never be medical frailty. We won't come to that consideration. It's because there will always be other options for a member to provide that documentation. If that helps answer that question. And then to your second question about what was considered as part of the estimate of enrollment loss, we did consider both. So as Julie mentioned, about half of individuals, we used a recent month. It was actually February 2026, just for the sake of saying a recent month. How many people were we able to determine based on our existing data met one of the exemption criteria? That's roughly half. And then on the remaining non-exempt individuals, we came to a rough estimate that 50 to 65% would meet the qualifying activities. Just acknowledging that none of us have a crystal ball. We are open to different estimates that may be out there, but that was just our estimate that resulted in that final figure of an approximate 17 to 25% enrollment loss.
Thank you, Brian. No, I know that you guys are we just wanted to know if that was considered in the modeling. We didn't even know if that was like something that was like possible or anything like that. So that's helpful for us to know. Because if it wasn't included, we would expect it to be maybe a little bit higher, but it's just a prediction. We've never really done anything quite like this. My last question was just, as you guys were preparing ahead of the interim final rule, are there any like I know you guys were aware that the interim final rule might have changed some of your plans, but are there any specific areas that were impacted? I know there's been like the HR1 work group and stuff like that, but since the release of the interim final rule, are there any areas that you guys really have to like redo or backtrack or change plans on because of what was actually released in the interim final rule based on what you guys were working on before? Because I know that some states got into like the pickle where, they were working off what they thought was going to be in the interim final rule. And then, that wasn't the case.
Yeah, no, that's a good question, Rachel. I can take that one. And obviously, Brian, Julie, if there's anything further to add, please do. But definitely the IFR presented, a deeper dive into our understanding of what we were working towards, not just for our state, but for all states. I think I've mentioned here and in other groups that, we've really leaned into our connections with other states and CMS as much as possible. And we meet with them, on a regular basis. And I think some of the things that stand out from the IFR, other than the medically frail that you were all aware of, is, just key terminology. A lot of states really struggled with trying to simplify the terms around, the who's an applicable individual versus a specified and excluded individual versus an exception. And that can get really confusing really fast. And so we've worked as a group and identified that as something that stood out, and we are reworking our policy and systems and materials to be more clear on that, as well as other states. I think another couple of areas that I would point out would be, the short-term hardships. And, if you choose the short-term hardships as a state, you can't pick and choose which ones you want to take. You have to take all of them. So I think that was new for some states. And then obviously some other nuances. We've identified, just I guess for transparency, over 60 tasks for our work group that we have to incorporate into our work and work to quickly modify, anywhere from our policy to systems to training and so forth. So yeah, quite a few changes that came out. I'm happy to dive deeper into each of these or even offline, but we definitely learned a lot more with the IFR and the release of the guidance. So I don't know, Brian or Julie, if you have anything further, but I think that kind of captures that.
I think you covered it well. Thanks, Michelle.
Yeah.
Thank you, guys. That was really helpful. Any other questions right now? Okay, hearing none. I believe it's back to Julie for the director's report, but you can correct me if I'm wrong there.
I'm sure. I'm happy to jump in here. There were a few items I wanted to touch on, first starting with program integrity. So we've had a flurry of activity in the program integrity world that we realized we needed to report out on here. So and on April 23rd, we were issued a letter from CMS, from Dr. Oz, and the letter went to state Medicaid directors as well as all state governors, and requested that each state take action to protect against potential fraud, waste, and abuse. And the actions that we were requested to take were to submit a 2-year provider revalidation strategy within 30 days to CMS. And the ask from CMS was that we start doing what we might call off-cycle provider revalidations, especially for high-risk providers and for providers who don't have a national provider identification number or NPI number. And then it also asked us to offer up some performance metrics to measure the efficiency and effectiveness of our strategy, and then also offer up our plans for coordinating our efforts with law enforcement partners. So Medicaid, we submitted a response to this letter. We agreed to do these off-cycle provider validations, and we submitted our plan and our response on June 4th, 2026 to CMS. And in our response, we committed to taking 3 main actions. And the first was to move our high-risk provider screenings up to a 2-year timeline. So under federal regulation, there are some providers that are already designated as high risk, and those providers are durable medical equipment suppliers, home health agencies, skilled nursing facilities, and opioid treatment programs and hospice. And so those providers, historically, what it means to be a high-risk provider is that you undergo more screening than other providers. So there's fingerprinting, background checks, and then importantly, we also do, there's a requirement that the providers have site visits, both pre-application and post-application. And those screenings are supposed to take place on a 3-year basis. But we've agreed now to do that on a 2-year timeline. Go ahead, Andrea, so you've got a question.
Julie, I was just I read it I read it once when this thing came out, but I can't remember it because it's been a while. So I'm wondering if you could define off the top of your head what CMS means when they say high risk provider.
Yeah, so high risk providers are, and I'm going to paraphrase a little. I know it'll disappoint to know I don't know the regulation by heart, but it's just providers who historically have had a higher risk of fraud, waste, and abuse. It's I guess I wouldn't say it's easy, but it's easy for a DME provider to send out too much durable medical equipment or bill on services saying that they've delivered the durable medical equipment. That's something that's difficult to track. And so by having these extra screenings, we can go in and make sure that the stores actually have durable medical equipment that they say they're selling, things like that. And so it's really just any provider that has, I guess I would say it's quote unquote easier. There's been historical trends of fraud, waste, and abuse in those areas. So we've had this historical bucket of providers that we've considered high risk. And then in May 2026, we actually used our discretionary authority to designate applied behavioral analysis or ABA providers as high risk, as well as some substance use disorder providers as high risk. And that information is going to be forthcoming in a MIB, but they will be subject to these high risk screenings going forward. I would also note that there are some high risk providers who don't have an NPI or a national provider identifier. So we, Utah Medicaid, recognizes some non-healthcare providers as being eligible to enroll with us without an NPI, and we refer to these providers as atypical providers, and they include a lot of home and community-based service waiver providers, some non-emergency medical transport providers, case management and peer support vendors, and personal care attendants that might be hired directly by individuals or families. And so within that grouping of atypical providers, we also do a leveling. And so some of those providers are considered high risk, and we also subject those providers to enrollment and increased screenings based on their risk level. And so with this plan, where we have been asked to truncate or speed up the reviews of our high risk providers, we had initially proposed a phased approach where we would take the existing high risk providers, so those that we had historically considered high risk, and do a review of them within 6 months. And then we would also take those newly designated high-risk providers, so the ABA providers and the SUD providers, and get those all within 2 years. That would mean we would be conducting reviews on 4,644 providers in total. And the trick for us on this is really staffing the site visits. For the providers, we can deem, so for CMS, for Medicare, they do site visits on a lot of the high-risk providers we had historically had. And so we can deem their site visits as our site visit. So that really helps with the administration. But these new high-risk providers, the ABA and SUD providers, they're generally not reviewed by CMS for Medicare purposes. And so we needed to figure out how we're going to get across the state and visit all of these places, because again, this didn't come with any appropriations. And so we have to do that with an existing staff and an existing budget. And so we are working to figure out how we might leverage our staff, the Utah OAG staff, and our Medicaid managed care plans. And maybe even if we have to look at whether or not we need to consider some contractors to be able to get out to all of these providers in order to do the site visits. So that was the plan we submitted to CMS, but our plans changed a little this week. I think that many of you probably saw that on Monday, we actually issued and were approved by the federal government to have a provider moratorium for any new mental health and substance use rehabilitation providers. And we did this based on some concerns regarding potential fraud, waste, and abuse. And we're allowed to put moratoriums in place when we suspect that there may be issues. So we put this moratorium on in order to do the high risk screenings on the mental health and SUD providers and speed those up. That wasn't originally part of our plan, but we're going to speed those up. There's about 132 providers that we have who meet the criteria, and we'll be going out and doing site visits and conducting the higher level screening. And there's also some other activities that having this moratorium will allow us to undertake in order to strengthen some areas to prevent some fraud, waste, and abuse activities. I would note that there is an exception process. So we don't, this is always a balancing act of making sure we want to make sure that we have good providers on our panel. We want to get the bad providers off our panels. And we want to make sure that we don't impact member access in an area where, quite frankly, we know we struggle with access as it is. So we're trying to do this in a very balanced approach. So there is an exception process built in so that we can get good providers on the panel. These activities, we're taking some of this, taking administrative action in response to a fraud scheme that the Medicaid Fraud Control Unit, whom we call MFUCU, that they've identified. So on Tuesday, you may have also seen that MFUCU and the Attorney General's office, they issued a press release announcing that they are charging a provider with violating the Utah False Claims Act for submitting nearly $1 million in false claims to Utah Medicaid. And so the provider who was named, the allegations are that they recruited parolees, unhoused individuals, and individuals with substance use disorders by offering rent-free housing in exchange for their Medicaid information. Then they billed the state for therapy sessions that witnesses and former employees said never happened. And the providers, when it was subpoenaed, was never able to produce records. And so MFUCU had shared that information with us. So this moratorium will allow us to review our existing providers, get prior authorizations in place for the services that had previously been exploited, and getting reporting mechanisms and other actions. So you may have guessed by that description that I gave you that they were really targeting our TAM members. And so there weren't any managed care claims involved. This really was targeting our TAM membership. So I'm going to pause there. I know that was a lot of information that I just gave you. And so I'm happy to answer any questions or take any comments that you have. And I saw that I also really want to highlight, we have Kaylin Wooten on the call. She is the director of the Utah Medicaid Fraud Control Unit. And I just have to shout them out because some states struggle with their Medicaid fraud control units, and we just have a top-notch Medicaid fraud control unit thanks to Kaylin Wooten and her team. And so I just want to also give a shout out to Kaylin because she's just doing great work with her team in this area. So I see, Stephanie, you've got a question. Have you talked to all those members? Have they been able to get the healthcare they deserve? So we have pulled membership reports that the team is going through. The tricky part of this is for us in reaching out to them is we don't know to what extent the individuals might not have even needed services. And so we are going through that list and trying to see if individuals got connected to services in other areas. And so we are working on looking at the individuals who were identified, who were impacted by this and trying to get in touch with them. Are there any other questions I can offer there or answer? Okay. Hearing none, I wanted to have a discussion with you all about our Medicaid budget. So right now we are undertaking our closeout activities to close out our fiscal year 2026 Medicaid budget. And right now we're expecting to close out over budget on our general fund appropriations. So we are about $100 million over what has been forecasted. We had a $30 million buffer that we had baked into the budget, thinking that there might be some concerns of going over what had been forecasted, but that still leaves us $70 million over budget. And so we're expecting that we will need to make a request to the legislature to appropriate $70 million from the Medicaid Stabilization Fund. And so you might be wondering, how did we get here? So we have kind of identified, the Medicaid budget's very complex, so there's a lot of nuance to this, but there's some large driving factors which led us here. So the first is we are still dealing with the fallout from two big black swan events that happened. So those black swan events are PRISM implementation and the unwinding. So when DHHS implemented PRISM back in March of 2024, there were data conversion issues which caused some errors in our enrollment data. And, you know, the PRISM system has been fixed, and those enrollment errors going forward shouldn't occur, but there was a period of time when the enrollment data was incorrect because of this data conversion issue. And so PRISM went live in March of 2024, and we subsequently had the unwinding in April, the next month in April of 2025. And so I think most of you are aware that during the public health emergency, there was a rule at the federal level that if you got on Medicaid during the COVID public health emergency, you were left on the program, and the eligibility was maintained, absent some exceptions. And so in April of 2025, Utah had its highest Medicaid enrollment that it had ever seen. There was about 500,000-ish people on the program, when our normal enrollment is about 350,000 individuals. And so over the course of 2025, individuals were taken off between April 2025 and April 2026. Or I'm sorry, April 2024 and April 2025, individuals who had been kept on the program because of the requirement for maintaining eligibility. DWS did a review of all of those individuals and unwound that. So while we had these PRISM issues with enrollment, the data conversion issues, we were also dealing with trying to figure out, you know, whether the disenrollments or enrollment issues were appropriate. People had been disenrolled because of the unwinding, or if the enrollment issues were because of the data conversion issue. And as you can imagine, eligibility data is very important for our forecasting. So fiscal year 2025 contained some eligibility assumptions that weren't quite right. And those eligibility assumptions from fiscal year 2025 was also carried over to fiscal year 2026. And so we had that issue as just an underlying problem in our forecasting. The second thing that has kind of led us here is, this sounds counterintuitive, but generally speaking, when we have drops in disenrollment, we don't necessarily see a corresponding drop in our costs or utilization. Imagine if you were an individual during unwinding, maybe you could have stayed on the Medicaid program, but you're not a utilizer of the program. You don't need to go to the doctor. You're probably not going to try to get back on the program, but individuals who, you know, have chronic conditions or actually need to access healthcare, they're going to make sure that they stay on the program. And so we still have, you know, significant utilization and significant acuity in our population, despite the fact that a lot of people drop from the program. And the forecasting models didn't really take into account that the costs would not trend down with the utilization. And so that also caused some of the complexity here. So what are we doing? We have right now a GRIP project where we're working with the Governor's Office of Planning and Budget, as well as the Legislative Fiscal Analyst's Office. We've actually had a project going for almost 2 years to modernize the Medicaid forecasting model. And so we have a forecasting model now that we feel really confident in terms of its ability to adjust to the utilization and the acuity that previously we hadn't. And then we're also going to be undertaking a reviews to see what other mechanisms we can put into place to address some of the cost drivers that are driving up our budget. And so we know, again, that we are going to have to be requesting that money from the legislature. There's a process by which we do that. We will go towards it before the Board of Examiners and make the request. We think we qualify for the funding under the statutory requirements for the Medicaid Budget and Stabilization Fund. And so we'll be moving forward with that. Stephanie.
Thanks, Julie. I just want to make sure I understand a piece of what you're talking about. So it sounds like, and I think that we all know that this is kind of how the system operates. Like, I mean, we said during unwinding that the people who really need the healthcare services, who are constantly ending up back in the hospital and therefore would like talk to somebody about presumptive eligibility, or they would like be using help from their providers, or they would just like find the willpower to just like get through the paperwork. Like, you know, we've designed an eligibility system, not you and I, but like our state has an eligibility system where it almost is telling people that it really is about like, do you really need it? Like, it's not just like, hey, you should be on Medicaid because you financially qualify. It's like, if you really, really need it, here's the safety net for you. And so it's like that it is going to lead to the people that are on it being more sick. But that also means that during the public health emergency, and this was brought up frequently when I was on the MAC, because I brought it up. I mean, there were people who were not utilizing healthcare because they didn't know that they still had Medicaid. And yet those monthly payments were still being sent to the health plans. And so I guess I'm just like, it unwound and the people left on were incredibly sick. But during COVID, like all of those payments that were being sent to the health plans probably weren't really always being sent for people who were utilizing a lot of healthcare, based off of what I hear you saying, which is that like the people that were left on are the people that were actually utilizing the care. And so are we sending, like, is the money that we owe, is it to the health plans? Like, are they saying that we owe them more money because it's like an adjusted payment because of the miscalculation of the acuity of the patients for the population that they're being given that member, you know, that PMPM? I just am kind of like, is that who we're paying? Or
No, I mean, there's definitely, well, so let me just say, you know, with the public health emergency, the reason why the unwinding existed is because there was a significant unknown as to whether or not, you know, we were lucky we got vaccines and other measures in place quickly to be able to curb the pandemic, but it could have gone, you know, easily the other way, that, you know, the cost could have skyrocketed because a bunch of individuals were being hospitalized. And that's kind of, you know, the interesting component of a risk-based contract, which is what we have with the managed care plans, is that, you know, they accepted that risk that it could have gone either way, right? And so, you know, I can't speak as to the past practices of what could have been in place to kind of address that function, but it could have, I would just point out, it could have gone either way. And so with what we have going forward, although there is a managed care component to the budget shortfall, there's also a significant fee for service component to the budget shortfall. And it really is, again, because of the utilization or the enrollment numbers. It really was because of the enrollment numbers, which informed all of the budget mechanics, and then just the drop in utilization that was expected from the forecasting model didn't occur because of just the population. And so I don't consider this a managed care problem, but there's definitely, you know, rating components in there.
oh, thank you for that. I guess just to follow up, sorry, Emma, I know your hand is up as well, but
And that's fair that it's both fee for service and managed care, I guess. But the idea of like, we know that there's financially eligible individuals that are not enrolled on Medicaid. And so, I mean, our enrollment numbers are not, isn't it accurate to say that our enrollment numbers are below what was projected, but you're saying the utilization of those who are enrolled is above expectation?
Yeah.
Okay. And I guess, yeah, I would just say I feel like that is in part due to the failures of our eligibility system, because it is forcing people to, like, it's not having people enroll for when they're just healthy and financially eligible. It is almost forcing people to be enrolled based off of how sick they are, not just are they financially eligible. And I would also guess that both for fee for service and managed care, it would be difficult to keep members healthy if when they're healthy, the incentives to do the paperwork are not there. And so I just hope in those conversations with, you know, the other, like just the various leaders of our state, I hope that I just think that should be a recognition of, like, I think this is almost like a product of some of the failures of our eligibility system to enroll people who are eligible, regardless of whether they're sick and also financially eligible, but just they're financially eligible and therefore they're going to be enrolled into expansion. That's just one of the comments that I have. Sorry, I'm not on the Mac anymore, so I apologize for taking up time, but I appreciate you addressing this.
No, thanks for your comment, Stephanie. Emma?
Yeah, just a couple of things, Julie. First of all, I just want to thank you for being so candid and so forthright about, you know, everything that kind of led us to this point, and the solutions that you're developing, you know, to address it. But the other thing I wanted to say, and I'm glad you already addressed it, is it is an issue across the board for Medicaid. It's not specific to the managed care plans, although working for a managed care plan, I will tell you that we have seen significant increases in costs. You know, it's not only utilization, but because the populations that we have now have more chronic or more even acute situations, they are higher cost. The hospital stays are tending to be a little higher cost. The pharmacy is higher cost, and so it's just all these issues that are occurring all at the same time: higher acuity, increase in cost. You know, we don't have the members, and I totally hear what Stephanie is saying, and don't disagree with what you're saying. But you know, it is now a program that's basically attracting mostly people who need services, right? Who need them now, and who are a little bit, you know, sicker and a little bit more high cost. So just wanted to agree with you, Julie. It is an issue that is just across the board, probably not just for Medicaid in that regard, but for a lot of payers, right? Just the increased acuity of individuals. So
Yeah, thanks for that comment, Emma. And that makes me realize I should have also mentioned Utah is not the only state that is experiencing this. There are quite a few states that are, you know, after the unwinding now are facing significant budget shortfalls because of the rising costs and rising utilization.
Can I ask one more quick question, Julie? Just
of course.
So we owe $80 million. Who do we owe? Like, who are the checks being cut to?
So I guess, so I'm trying to think how to explain this. There's not like a specific person to whom the checks are being cut. These are costs that we have either incurred or accrued over the course of the year. And so there could be some costs that we've accrued or expenses that we've accrued that we've yet to pay out. And some costs that we're anticipating. And so like, it's hard for me to pin down to tell you exactly who the checks are getting cut to, because it's providers, it's managed care plans, it's risk corridor settlements. It's like, there's a lot of things out there. There's a lot of things out there that these expenses are tied to.
So then is it, and then does that mean that the feds also owe them? Like, so is it we're short that much, but the feds are also like, is that just our match contribution? Like, so if there's unpaid things, does that mean that like the budget was really off like $400 million?
So this is a general fund shortfall. So this doesn't include any expenses that we're paying out of like expansion. This doesn't include our administrative budget. It's a general fund shortfall, and the expenses that are eligible for the federal match will be eligible for the federal match.
So the shortfall was maybe it's a general fund shortfall, but like the budget projections were off more than just the general fund shortfall.
So it was what we projected we needed in general fund was short.
Okay. And then, sorry, this is my last question, is just, did we know this? Like it feels like this is, the budget ends next week. So like the budgetary year. So did we know this at like the end of like Q3 or whatever? Like, I mean, when did you all know that we were this off?
The number I just gave you, it's been changing with the closeout. And so we've understood that there was going to be a shortfall for a little while, but didn't understand what the scope of it was going to be until we started to see these final numbers come in. So yeah, in terms of when we've known, we were anticipating it, but we were also doing everything we could in our due diligence to make sure that we were checking our numbers, because we don't want to come in and say we have a significant budget shortfall, it's this number, and then closeout actually leads to something different. Are there any other questions I can answer? Okay, Rachel, I'll turn it back to you.
Thank you, Julie. I appreciate it. I believe the next on the agenda is Michelle Smith with an eligibility and enrollment update.
Okay, thanks, Rachel. I will display my screen. So 1 second. Okay, so the first screen and data that I will go through is just overall enrollment. So again, if you're not familiar with this webpage, it is available on our website. So anytime that you want to look at this or, see what's going on, this is updated monthly. So I'll drop this in the chat here for you all. I'm on the persons tab, and as you can see, there were some modifications made to this so that we could be compliant with ADA. If you want to access the full data set, you just click to download that. So I'm going to pull up that spreadsheet right now to show you what that looks like. So here in column C, you can see for May, our total enrollment is 331,165 individuals. And I went through each of the programs. Off to the left here shows the program types. There was nothing that truly stood out as significant in terms of increase or decrease in enrollment. However, I do just want to kind of highlight the child group here. Over time, I did see it's like a very slow, slight decrease in enrollment. And I did touch base with Brian Roach and just try to figure out, troubleshoot, maybe some thoughts on why this declined. And I don't know, Brian, if you want to maybe touch on this a little bit, if that's okay.
Yeah, I mean, of course, this is one hypothesis, and we welcome thoughts from the entire group. But I think if we look at the newborn group, that really does give some indication of much fewer births, especially maybe going back to the graph. It's kind of hard to see the newborns among the group, but if you deselect everyone else, what we can see is newborns are less than half of what they used to be, which speaks to lower births among Medicaid, which I think in turns is leading to a substantial drop in our child population. Obviously, things are never simple as one factor. I think this might be one of the largest factors, but that seems to me to be one cause in why our child enrollment is dropping, as we've seen over the last year.
Thanks, Brian, for helping with that. So this is the overall enrollment. Again, I think this is the only group that I would flag for you all. I'll move next to the eligibility data dashboard. This is also available on our website and updated monthly with information on here that we share to CMS, as well as some other information on eligibility. So this first tab, review outcomes, you can see our ex parte rate still around 35%. So just noting that, I mean, we always look for ways to try to improve that or increase that, but it's definitely all of our efforts we did to automate and do some other things that has increased over time. I won't go through each of these tabs, but I'll point out just call volumes. I know that's one where we get a lot of questions as well. Average wait times just slightly up a little bit from April to May, and abandonment rate, just we're working, just so you can see, it shows 2100%. That's off. We're working to get that corrected. So if you go to this and see that that's not accurate, it's 21%, not 2100. We're getting that corrected. And then the last data that I'll share with you is the 1115 dashboard. I really won't go into too much of this, but if you are interested, I'll drop the link in here as well. This is updated monthly into our different demonstrations under our waiver. So the enrollment tab and then benefit tab with the different demonstrations that we have in our waiver, if you're wanting to know more about that. So I will stop presenting and just ask if there are any questions for me.
All right. I don't see HR or any other, sorry, I've got like one thing on my brain, obviously, and it's HR1. I'm not hearing or seeing any other questions. That takes us to number 9, which is committee member updates. So I will be quiet for a second and see if anyone has any updates. Feel free to share those in the chat or come off mute. All right, hearing and seeing none, I will pass it over to Sharon for the voting results for the budget recommendations.
Okay, thank you, Rachel. I am going to share the results. As always, I will, in case anybody is on the phone, not sure if there is, but I will just read these down in order. I did have all of the committee members vote, so thank you very much. I did receive everybody, so we have a full vote this year. And pull this up on my screen so you all can see this. Okay, so another thing to note too is, so when the MAC members, when they vote number 1 as their priority and number, I think it was 19, as their least priority ranking. among all of the presentations. So the lowest score is actually reflective of the highest priority. So that's why you'll see this here sorted by the lowest total score is reflective of the #1 priority of the MAC members. So in that position is the mental health system and Medicaid. Those were the 4 rate increases. As #2 is the Division for Services for People with Disabilities. This one had 3 HCBS requests to it. For #3, it was the additional DHHS and DWS staff and the DWS call center hours to support community engagement and eligibility checks. #4 was the DME rate increase for incontinence supplies. #5 was the standardizing fiscal management services fees. 6 is the pre-TRM, preterm birth test. 7 is the ColoSense performance data. #8 is the laser ablation therapy for epilepsy surgery. 9 is the refractory epilepsy patients. 10 is the cranial remolding orthosis, if I said that correctly. 11 is the therapeutic footwear. And then, as you can see here, with a score of 209, 3 different presentations, all scored 209, the marriage and advanced wound matrix, the tumor treating fields, and the coverage of CPT 98975 and 98978. So then 13 is the NAVDEX, optimizing HPV plus cancer care. 14 is the Visitism VNS system. 15, the MI Cancer Seek. 16 is the Utah Metabolic Health Pilot. And 17 is the Thyroid Diagnosis Test Affirma, CPT 81546. I will send out these results via email to everyone, and they'll, of course, be posted on the website along with all of the other presentation documents. So that is the voting for this year's MAC budget recommendations. And this will also be sent to the department leadership for their consideration. So thanks, Rachel.
Thank you for doing all that. I know it's your favorite meeting of the year. Or meetings, I guess. All right. Any last requests, comments, concerns from anyone before we adjourn? We have made it to the end of our agenda. All right. Hearing and seeing none, we are done. Have a wonderful July, everyone. Enjoy your summer until we see you again in likely August. And have a great rest of your day as well.